A coin, yes. Then we're going to get into some of the other things that we talked about yesterday with all that itching, some of those atopic things, some of those stasis things. So it's not moving around and yada yada. So here are some facts regarding eczema in and of itself. So it's the most common inflammatory skin disease. Oftentimes we call it one of the dermatitis. However, it's inaccurate, right? So imprecise. There are many forms of the dermatitis, but eczema is not one of those. Eczema is in and of itself, and it's going to require all of those different things that are out there. Okay? Characteristics. So you're getting some of that redness, erythema, right? You're getting some of the scales, some of the vesicles, some of the itching of the pruritus. Okay? Eczema hurts. My 15-year-old daughter has had it almost since she was a young kiddo. In pediatrics, y'all will probably learn about a triad, right? So a kid that has eczema probably has allergies, probably has asthma. Like those three things oftentimes run together. Again, I'm not going to test you on that. I'm just letting you know. 3 stages: acute, subacute, chronic. So where are they at within that? Basically, is it starting now, or has it started but isn't? But then they have that chronic one that has always been there. Okay? Each one is a stage of evolution of any dynamic inflammatory process. So it can occur, throughout that. So here's acute, right? So they have those of the vesicles, of the bulla, intense erythema. So it's red as hell and it itches. So they're scratching at it nonstop. If it's acute, because they're not just used to it, it's starting off. And so they're like, ugh. You can have all of this because of some type of a contact allergy, okay? So you get that acute nummular. I'm going to stop this for you, okay? Y'all enjoy. But that regular stuff is just irritating the shit out of me. All right, so we got that acute nummular eczema, stasis dermatitis. We got the pompilites. Treatment-wise, we talked about the cold, wet compresses yesterday, but topical or oral steroids are one of those big things. With eczema, which group do we think it's going to be? Is it one of the strong ones or one of the 6 or 7s? It'll be right smack in the middle, but then we know afterwards if we're going to go higher or we're going to go lower. If it's a kid, am I going to go lower or am I going to go higher?
Lower.
I'm going to go lower or stay right smack in the middle, okay? Antihistamines help what? Well, it can knock them out, right? Sleepy time. Here you go, kiddo. I don't know how many parents have done that, but sometimes Benadryl is good around nighttime. But it'll also help with all of the itching and stuff, okay? Antibiotics, if there's some type of a secondary infection. So this is all acute. Subacute, again, redness, scaling, fissuring, right? So that is that straight thing that can happen on of a linear aspect, right? So it can go down the lips, but we most common see those on of the inside of that. So if they're scratching so much, then they can have some of that the fissuring. We're also seeing parched appearance, scaled appearing, moderate itch, pain, and burning. Okay? Some of the things that are causing also that subacute is a type of allergy, irritant, atopic, astiotic. Okay, so those are some of those components of eczema that get into the subacute phase. Again, Topical steroids, occlusion, if it's severe, then we want to cover that stuff up, whether we're going to put those things on there. Emollients, right? So Aquaphor, those other things out there that they oftentimes use. Antihistamines, antibiotics if indicated. So it's almost the same of the acute one, but now they've had it for a while. So it's like boom, da boom. Now you get the chronic one, right? It's been there forever. Thickened skin, like kinification. Extenuated skin lines, excoriations, fissuring, moderate to intense itch. So you can see there, and we're going to talk about in a little bit how you can get that LSC. So you get that over scratching back and forth and that kind of stuff that causes or creates that scaling. Again, I love when I say things that are written down, but I've already seen this slide like so many times that I just don't know what to say. So again, atopic dermatitis, habitual scratching, LSC, that's that lichen simplex chronicus, which we're going to talk about after we get through eczema. Definitely, if it's chronic, we see that with occlusion. With subacute, we were talking about, maybe we have to occlude it, but with chronic, we definitely want that, okay? Again, antihistamines, emollients, and antibiotics if it's indicated. Why would an antibiotic be needed? Well, it's probably if they're scratching it way too much, that stuff is getting into it and causing some more of that vesicles and bullae and all of those other things that you know, hey, something's cray-cray. All right, so we talked about acute, subacute, and chronic. Now let's get into those three types that are out there. Number one, dyshydrotic eczema. So that's that distinctive reaction pattern. So you've got symmetrical vesicle hand or foot dermatitis. So it's not only on one hand, it's on both. Not only on one foot, it's on both. Okay? So it's symmetric. Moderate to severe itching precedes the appearance. So it's hurting first and then it pops up after. Most common in teens, middle age. Why does it happen? We don't know. It's got an unknown etiology. Possible relationship to stress or irritants. Okay, so they're working at a job or something that exposes them to some of the things that they don't like. Okay? Patients might have hyperhidrosis. What does that mean? Hyperhidrosis. Exactly. Okay? And that's what it looks like. So you get those papular vesicles, other things on there. If it's on one hand, it's on both hands. And you can see how it's raised up. And it's, you know, it looks like hyperhidrosis, right? Because there's so much stuff happening that it looks like if you slap me in my face, then you're going to get me wet at the same time, okay? All right, more about it. So you get those multiple tiny deep-seated vesicles with surrounding erythema. Key component is that line right under it. Tapioca. How many like tapioca? Never had it, but it looks like that, right? So tapioca, that's dyshydrotic eczema. Again, as we said, you got the palms and lateral aspects of fingers, of hands or feet. Those palms are red and again, wet with that perspiration, that hyperhidrosis. Very itchy, very fluidic that is out there for those things. Vesicles slowly resolve in 3 to 4 weeks, but once they do that, they're replaced by some of that scale. So the tapioca goes away, and then we get that scale. Replace we have. Progression to lichenification and cracking, peeling, or fissuring can be one of those things that also happens, right? Okay. Pain then replaces the itchiness. It's not only itchy, now it hurts, right? So they get that pain. If they're having some type of a secondary infection, then that obviously is going to be problematic. And we talked about all of these things, that if it's severe or we're having some secondary aspects, then we would have to do some type of an antibiotic. Distribution, I said it earlier, it's not on one, it's on both. So you'll have that beautiful tapioca. Have I said that word a lot? Tapioca on bilateral aspects, okay? One side may be worse, but it's on both. It's localized on the lateral aspects, okay? Yes, we can have it on the palms, but more often it's seen on that inner sides of the fingers, okay? It's more severe in those areas there. Etiology-wise, it's related to atopic dermatitis, so there's some of the things out there that just irritate it or cause it. Suspect that irritants are the primary cause. Irritants are the primary cause. Management-wise, potent steroid, then wean. So potent steroid, we're talking about where we're going to start at, right? So we're going to start at 1, and then as we're getting better, then we can go down and get those things out there. As it says, class dependent on the severity, okay? If it's you giving number 1, well, let's occlude it at the same time so we can knock it down and we can take them off of that high potency. Lifestyle modification, so let's avoid those irritants that are out there causing us to have that. So we want to avoid water, irritants, trauma. We're going to use some of those bland of the emollients. Again, of course, if we think that this is some type of an infection process, then we'll prescribe some of those antibiotics. Do I list the antibiotics on here? No, okay? So you just know that an antibiotic can be used. Like before, antihistamines. So Atarax, Benadryl, those are the two out there. They have the special generic names. Cool, wet compresses. Let's talk about the diet. Let's talk about PUVA, right? That's something that the dermatologist will use, and I know that that's true because I've seen it. Low dose methotrexate, okay? Methotrexate is one of those things that systemic-wise can suppress some of those things out there. Mr. Souffle has had that before, but then I wanted something better, so they put me on Ozella. Yeah. Anyways, so I told you how it's on those inner sides. Okay, that's the most common side. Yes, it's going to be on my palms, but it can also be in those finger areas. Again, what's the look of it? Tapioca, dyshydrotic. You can see there of the palms, fingers. Is it on only one? No, it's on both, so it's bilateral. Other than this picture right here that is showing you the palms, where else can this happen? On the feet, right? So you can get it on that plantar aspect of the feet. All right, so that's the first one. Now let's get into the second one. Astiotic eczema. Eczema craquelé. Never used that, but da-da-da-da. What's in bold right there? Winter itch. So this one is a winter itch. Occurs after excess drying of winter months and among the elderly. So the old winter itch. Atopic patients more likely, and it's more of an itch than an actual rash, right? Morphology-wise, we'll see that on the lower legs, becoming dry and scaly. with attenuation of the skin lines. You'll see some of the plaques with thin, long, horizontal superficial fissures. Again, this looks like a damn scraped up toilet. So you get that cracked porcelain, right? It's that porcelain. I said porcelain. Porcelain. Okay? Y'all are going to hear so much funny stuff coming out of me. I'm not going to say circumcision anymore. All right. Plaques, again, it can have some of the redness, right? But it's not big, so it can be minimal erythema. Distribution, you see that on the anterior lateral lower legs primarily. It can happen anywhere, but this one right here is those old winter itch of the lower legs of those old people. Why is it happening? Well, you got that cold, dry weather, okay? You've got those long, hot showers. These are those things. Because it's cold, they want some hot water or something. Who knows, okay? Management, we're going to use those emollients. Again, like before, we're going to use that right after the bath because our skin is all moist because it's happy and it feels great. So then we're going to put those things on there and get it trapped in before it becomes dry and doesn't let it in. Modification of the skin care. So decrease frequency of bathing and temperature. Okay, so don't make it super hot. Okay, so have a warm bath. Change the soap. I like how it says Dove. I don't know. Whatever soap is out there. Steroids. Short-term group of what does that say? 3 and 4. Okay? And then moisturizing emollients, like we talked about before. If it's severe, if it's having oozing, crust, infection, then we're going to do those wet compresses. So we're going to put that wet stuff on and over them, but then we're also going to use those antibiotics if we think that there's some type of an infection process that is out there. Okay? Immediately after bath, we know this is older people, winter itch, lower legs. That's what it looks like. Again, that's that toilet messed up, right? So it's got that porcelain stuff that looks like it's cracked, okay? All right, so that's astiotic. Last one, nummular. Middle-aged to elderly, so most patients are greater than 50 years old. May reoccur in the same spot every winter. So it's like you're a millionaire with nummular eczema, and that coin is going to be in the same spot every time. Okay? So it might go away, but it might come back every winter. So this is a winter one also. You got that intense itching. You got that habitual scratching, which gives you lichenification. Morphology, so intensely itchy, pruritic, erythematous, discrete, and then in bold, the word that I've said since yesterday, now today, it's coin-shaped. 1 to 5 centimeters in diameter. Thin, spare scale that may flake. They become thicker with vesicles on the surface. So you can see those things, okay? So what would be of a differential diagnosis if you're seeing those vesicles? Well, let's go to dyshydrotic eczema. Because it's winter, let's go to astiotic, right? So the different types of eczema will jump back and forth. And like I've told you a lot yesterday, there are key components specific to each one of them by itself. Okay? Again, coin in Latin. Piece of money. All right? Give me 1,000,000 coins. Just don't make them pennies. Like, I'll take quarters that are fine. Okay? Distribution, most commonly on the lower legs and upper extremities, but you can also see this on the dorsal aspect of the hands. Why does it happen? We don't know. It's unknown. Management, you can see there, 1 to 3, right? Each of these have different groups. And I told you all that I only care about the groups that you'll use, okay? Consider occlusion with this, correct of the dryness of the skin and environment. So if you've got some exposure irritants, we'll stay away from that, okay? And of course, we're going to give some of that anti-itchy stuff if it's needed, if they're like da-da-da-da-da. All right, the first picture you see on the dorsal aspect of that hand, right? So you can see the primary one is which one? The one that looks like a coin, right? So I'd say that's not a dime. Let's say it's a nickel, right? But then you can see the fact that it's itchy. There's some of that like kinification that's around that. So you've got that on that finger area. The other picture, that individual is, millionaire again, okay? So if there's so much of that happening, then it doesn't look necessarily like there will be coins inside of it, but it's so spread out that it's like out there. Again, where's the primary one? Right smack in the middle of that left picture. That's a quarter, right? So you can see that. And then over there, they're comparing it to it's a nickel, I think. Right? Yeah. I don't ever use those. Nickels. We're going to talk about nickel later because what do you think is the greatest irritant that's out there? Nickel. All right. LSC. Okay, so now we're out of eczema. We talked about one of them. Okay? Dyshydrotic, what's the key thing out there? I said it a bunch. Yeah, I heard it over there. The number 2 was astiotic. That's that what? Old people that are having it when? Winter. And what's the key of, what's the coin of nummular? See, it's like key, but I said coin. Anyways. All right. Lichen scipularis chronicus, that LSC. So it's localized, I'm not going to say that word, neurodermatitis. Okay, y'all can see that word. Don't write that down on my EOC. Mrs. Tuplay can't say this word because it comes out this word. Okay. Eczematous eruption created by habitual scratching. So LSC, habitual scratching. Any age, most common in adults, because we're all crazy in our minds and get that habitual scratching. Precipitated by seborrheic dermatitis, atopic dermatitis, nummular eczema, irritant, or contact dermatitis. Basically, they got something going on with their damn skin and they're scratching at it and won't stop. It's just addict. Okay? Nerve entrapment, and then it really itches. So if it's, so much down and into those nerve aspects, then they can have that there. Morphology-wise, red papules coalesce to a red, scaly, thick plaque with attenuation of skin lines. Okay, so skin lines. That's how they get into that. I've already said it, but that lichenification is secondary to the chronic rubbing. Are they rubbing? Are they scratching? Like, stop touching it. But it's not happening. You'll have, well, not you, but they will have excoriations, cracks, fissures, hyperpigmentation, so it gets darker than all of the other skin that they have. And then they can have nodules, prurigo nodularis. And we're going to talk about that one too. Distribution, you can have it anywhere. But it's convenient to those areas that they can actually reach out to, right? So scratching of the back of their neck. Some of them can't reach to areas of their back, so they can't have LSC there, right? Feet, all of that other kind of stuff. I think the back is like one of the areas that individuals can't actually reach out to. Because it talks about of those areas where you can scratch at. So the outer lower portion of the lower leg, the scrotum, the vulva, anal area, pubis, those things they can scratch at. Wrists and ankles, upper eyelids, upper back, orifice of the ear, extensor forearms, and behind the ear, scalp, all of those places where they can scratch. First off, stop it. Let's break them itching. I'm going to send them to damn psych or somewhere else. It's not a part of this, but that's what I would do. Like, you need to go to mental health. Let's help with that. Treat thickened areas with group 1. So we're going to go number 1. We're going to go intense. And then wean it with improvement. So once it starts to get better, then we can go to 2, 3, all the way up to 7 is where we want to be. Long-term therapy, soften and break down lichenified skin, right? So we want that lichenification to go away. We can use those emollients. Some of these people, right, we want to add in a first gen antihistamine. So we're going to use Atarax, or we're going to use some of the stuff like that, just so that even when they're asleep, they're not scratching. Okay? So knock them out. Biofeedback or behavior modification, again, because this is habitual. So let's go ahead and refer them out. That's not on here, so I'm not going to test you on sending them to mental health, but that's one of the things that you could think about. May require intralesional steroids if they're having those nodules that we talked about. If it's used, then they are injected with that the Kinolon, okay? Again, that would be some type of a referral. Those dermatology expertise would be the ones to do that. But just know that. Know if it's perineal nodules, that would be one of the things that we would want to refer for, okay? Because we know what the dermatologist is going to do. Pictures, back of the neck, right? You can have that dorsal foot, right? So they're sitting over here and just scraping back and forth and forth and forth. So that could be that LSC on the dorsal aspect. He's got it on the lower back that he can touch. Probably not in the middle of the back, but it can be the upper back, it can be down lower. He's even got it on his ass, right? He can touch that area. Some other places, again, I always go a little bit faster in these slides, but some of the other places where it talked about the scrotum and, pubis and that kind of stuff that can happen. So you see it there quick. All right, goodbye. All right. Now this one right here, prurigo nodularis. Okay, so this is more severe. So as you can see all of those nodules that are out there. Okay, we talked about the nodulars, right? And we're going to refer them to derm, and the derm is going to do what? Kinolon, right? So they're going to get up and under it. They're going to inject it. So that's why you would send them. Be like, damn, group 1 ain't going to work. So let's send you over there and see what they say. All right, so that is LSC. Now let's get into the types of dermatitis, okay? So first up, we've got stasis. So that is an inflammatory process caused by a decrease of circulation to the lower extremities. So if it's stasis dermatitis, it's our lower legs, and we are not having any type of circulation that is happening there. So it's not that blood flow that is down there. So that's that chronic venous insufficiency due to some type of a disease. So not only are they having this, but they probably have other stuff going on that is adding and causing this to happen. This one may cause itching, scaling, and hyperpigmentation. So they got that brown staining of the skin, so it's getting darker if they're having stasis dermatitis. If prolonged, they can get some of those ulcers that are, haven't been treated good to go. Pathophysiology. So slowing of the blood flow with microvasculature. So you've got that distension of the capillaries and damage to the capillary permeability barrier allows. Okay? Again, lower type of extremities that doesn't have good blood flow because of some type of another diagnosis that is causing that. And so that's why we've got it underlined there. Yeah, I can treat your stasis dermatitis, but we need to treat that other damn thing better. We need to do it more so that you start to have that the blood flow that can go down over there. And how do we do that? Well, we're going to give them compressions. We're going to give them some of those stockings that will help that out. We're also going to have them to relax in their recliner. Have fun, okay? Don't jump around like I did last night with the damn Spurs losing the Timberwolves. I was mad. I was yelling. We can also use some of the topical steroids. We can use those of the emollients that are just out there. Again, lower extremities as seen in the photos here. So we can see those things. That's that venous insufficiency. So it's going down, but it's not flowing around like it's supposed to be doing. So that is stasis. Now, atopic. Atopic dermatitis, we're going to say it on the next slide, but it's an itch that rashes. Chronic pruritic eczematous disease almost always begins in the childhood. Follows a remitting, reoccurring course. Because it starts with children, it improves as they get older. Not only that, but they have a past medical or family history of atopy, allergies, asthma, sinusitis, flares with cold, dry weather or hot, humid summers, seasonal pollen, stress, illness, and irritants are the things that can cause this to come around. Like I said before, the itch that rashes. Okay? What does that mean? Well, it itches first, and then afterwards, then you get some of that rash that happens. It is not the eruption that is itchy, but the itchiness that is erupted. Dryness that causes cracking, which causes itch, which causes the rash. Hereditary, thank you, mom or dad. Commonly have a history of asthma, allergic rhinitis, so they have that hay fever. May flare with acute allergic situation. So if their allergies are popping off because of the damn pollen outside or other things like that, then they can get this to happen. Morphology, erythema progressing to papules and plaques. So they have the flaking, xerosis. We talked about xerosis yesterday. What is xerosis, dryness, okay? Cracking, scoriation, fissures. It can be patchy or confluent. Again, after time, the itchiness, the scratching, then you can have lichenification, secondary staph with the flares. So again, if they scratch and scratch and scratch, then some stuff can get into it, and then bacterial-wise, set it off. Dermographism with firm rubbing, so that's what it can happen. Again, this usually starts when? With the children. It goes away as they're getting older, but that's where it's at. So infants 0 to 2 years, you got that dry red scaling areas confined to the cheeks. And by cheeks, I mean the face. Okay? Can be in other areas, but with cheeks, I'm talking about the face. Children 2 to 12, flexural areas. If you're seeing this in the flexural areas, what differential diagnosis would you also make? Eczema, right? It's in those flex areas. So this is type of a differential diagnosis. Face and scalp involvement, right? So getting up onto those cheeks. Patchy or generalized body eczema. So it's not in one spot, it's all over. Again, distribution as well. So we're talking now greater than 12 years, bilateral flexural creases, but it can be, anywhere. Hands, neck, waist, wrists, and ankles. Spares the face except for the eyelids. So once they get older, it's not on their cheeks anymore. It can be everywhere except, well, it can be on your eyelids, but nowhere else that is seen on the face. Lesions are often chronic and lichenification is present. So now here's a picture of that. So we can see those locations of where we can see that at, right? So young kiddo, you see those on the cheeks. If it's an adult, we'll see those on the eyelids, but it's not going to be anywhere else. We have those on the flexor areas, but we can see this on the hands, lower extremities. We can see this on the feet. Those are those things out there. So what pisses it off and it flares up? Well, these are those triggering factors. So temperature change, sweating, aereo allergens, right? So the pollens or whatever damn allergy that's out there because the trees and the grass are beautiful. Contact allergies, they're touching something, irritating substances, low humidity, excessive washing, foods, emotional stress, okay? So those are those things out there. So how do we treat it? Well, we got those goals up there. So multifaceted approach. We're going to use skin moisturization. We're going to use topical anti-inflammatory therapy. Eliminate infection if it's there. Identity, control, eliminate triggers. So all the stuff that we talked about up there, we want it to go away. If we are having some of that xerosis, some of that dry skin, then of course we want to hydrate. Wash it less often. Don't be taking a hot bath every morning, afternoon, and at night. Okay? Shorter bathing time. So if you're getting in there, don't be in there forever. Moisturize with emollients immediately after bath. So with atopic dermatitis, we talked about some of that inflammation, right? We're going to get into those topical steroids that are out there. So, cornerstone of anti-inflammatory management of acute exacerbations of atopic dermatitis. So, adults, mid to high potency. So, we're talking 3 to 4, 2 to 1, right? So, where we're going to go. Again, it says triamcinolone, Okay, again. Group is the most important thing for you to know. Children, we're going to get the low potency, right? So we're up to 6 or 7 because there are those kiddos who have not skin like us old people that are thickened or more of the epidural aspects. So we're going to use some of the lower ones in those kiddos who are beautiful. Daily 2 to 4 weeks. Once control has been achieved after daily regimen, then we can get into that long-term control and maintain that twice a week application. So it's not every day, but we can do it in other days. Pruritus, so break that itch strap cycle. So again, we're going to use Atarax, we're going to use Benadryl, we're going to use those things that just helps that to go away. Now, coming up next, how much do I care about of my family practice physician assistants? No. Okay, these are some of those things that we send them to Derm, and Derm is going to think about these things. So Elidel, Protropic, we used these back in the day, but you can see 2006 that we were getting some of these thrown away. Okay, so they're not used anymore, but it's just one of those things to throw out there that oftentimes these were used. I'm pretty sure one or some of y'all was born in 2005. I don't know. I mean, I would. Again, more of that, talking about those TCIs. Again, this was something that we don't need to know all about. You can put a big X on these 2 slides. Y'all heard like I already wrote that. Again, this is more of that derm stuff. So crisaborole, so that's a mid to moderate. So we're going to do those things out there. An interleukin 4 inhibitor, Dupixent. I've seen commercials about Dupixent, right? Those are all those things. For use, 12 years and older, moderate to severe. Those are those things out there. You can put an X on that one also. Here it's talking about where are they at. They're a light. So are they red, yellow, or green? And these are the things that we want to do depending on what that. Okay? You don't have to put an X on this one because it's showing you what the traffic light is looking like. All right? So we can see that red, right? We're getting in that active stuff. So we're talking about some of those things that are of the steroid, antihistamines. We're getting into some of the antibiotics if it's up that high. But then we're going to get, next one. Okay, we only have to use some of the steroids, so we don't have to go to number 1, group 1. Then we can be, smack in the middle. Low, then we'll go all the way down to hydrocodone and something low. All right, last one. And then because I've taken almost 50 minutes, I will give y'all a break, and then we'll come back and go through it quick. Keratosis pilaris. So it's an atopic dermatitis. So you'll see this, and it's a part of the differential diagnosis. This one right here, we see this in the childhood. So you got that spiny keratotic papules predominantly involving the extensor aspects of the proximal arms and thighs. So where's that at? It's on the outside, right? So it's out here. Basically, it's asymptomatic, but you got somebody walking in. Doc, what is this? I don't know what it is. Okay, you're fine. Run off. So you got those things. Typically asymptomatic. It's just one of those findings that you'll see on the physical exam. And then you all will ask, does that itch? How long has it been there? Anyways, clinical based on appearance and exam. The treatment, if it's a little bit having some of those symptomatic features, then we can use some lotions with urea and lactic acid. We could do some of them mid-potency. So if they're coming to you, how many times do you want to send them out getting nothing from you? I'll give you some Atarax or something. But in here, I could give you some hydrocortisone. Rub it on there, and you'll think it'll go away. May resolve spontaneously as the patient ages. Again, we can use some of that urea and lactic acid if they have similar types of symptoms. What does it look like? Well, it looks like that. Okay? Again, this is on the outer aspect of extremities. So it's out here, and it's just one of those things that you see. All right. So that is it. We talked about those 3 things of eczema. We talked about LSC, stasis, and atopic. And we lastly talked about that keratosis pilaris. Any questions? You have your hand up. Okay. All right. Let's go ahead and take a 10-minute break. Y'all walk outside and feel a little bit cool. And then I'll start up again. I'm going to stand in front of you.
I'll allow it.
It's on my back and I can't reach it.
The whole font was there. There's like 3 others trying to go. So many things. I'm sending it to you today. I got it.
Whoa! I like it. All right, so before we start, I just received my senior Clean Core list. So Nathan, Darla, Dakota, Sam, Emma, and Casey. On Friday, there shows that y'all have some of a block right after lunch. You six got a little bit lucky because you got me, okay? So after my lecture that day, then we will just sit and chat, and then you'll have a long lunch. So, yeah. Anyways. All right. So this is a quick one. Okay, this is contact dermatitis. We've already talked about several other dermatitis areas, but this one right here is in and of itself because it's either irritant or allergic. So something is pissing off the skin or something, well, I mean, both of them are getting pissed off, but one's an irritant because you're in contact with one thing, or other things are there. You can have allergic that is out there also. Okay? What is it? Well, it's a eczematous dermatitis from exposure to substances in environment. So you act as an irritant or an allergy. Cause that, acute, subacute, chronic eczematous inflammation, differential diagnosis that is out there, okay? So we're going to talk about some of the key components that will point you and lead to you thinking about some type of a contact dermatitis. So there's two main types. There's the irritant and allergic. So irritant damages that barrier, whereas allergic is absorption of that antigen with subsequent exposure eruption, okay? So it's got those things that are just causing that to happen. How do we diagnose it? How do we decide if this is an irritant or allergic? So if we think that they have some contact dermatitis, then we're going to send them to the allergy clinic where they're going to do that patch testing. Okay, so they're going to get all of those patches that will determine which is a allergic reaction that is happening to them, or an irritant, right? Because it's not only allergies, but they'll put, some coconut or some eggs on it. I mean, that can happen. Most common types. So you got that, well, let me break it down first, right? We're talking about the irritant, okay? So the irritant dermatitis, so occupational, of their hands, okay? They can be a dishwasher that always puts their hands in something that is irritating them. They can be some type of a farmer or something out that is like pest control that are spraying stuff, or, it's those irritant aspects. It can be of a diaper, right? So are we using some of the wrong lotions or powders or something else? Are we picking the wrong diaper brand that's just, irritating them? That can be part of it as well. Differential, of course, y'all know that this can be some type of atopic dermatitis, and it can be what we're going to talk about next, right? That's all a part of the differential diagnosis. Again, if you find a key component of this one, then that will set your goal. So this is damages to the stratum corneum. Which of the layers, of the 5 layers, is that one? It's up top, right? Acute, they have those vascular and exudative. Once it gets acute, then it'll go into subacute to where they get inflamed, cracked, fissured skin. And then it's chronic, scaly, flaky, lichenified with less erythema. Hands most commonly, but it can occur anywhere, right? So our hands are sensitive, but it can be in those other sensitive areas. Basically, that's thin skin areas that this can happen. Environmental exposure, this can be unilateral or this can be bilateral, right? I talked about of a dishwasher, right? They wash those with both hands, so it can be on both. If they're just spraying some stuff, then it can be on one hand or other hands. Who thinks I'm going to talk about one job, too? Etiology, contact with irritant, right? So they've got that. Management-wide, let's avoid that. On here it says change job. MOS, avoid through protective clothing, right? So put some damn gloves on. Put something on that will prevent you from that irritant. Emollients can provide protective barrier, cool compresses if it's acute, topical steroids for severe inflammation, potency based on severity and location. Okay? So we can use some of the steroids. If it's acute, then we're going to go into higher ones for an adult. If it's a child, then we're going to go into mid to low ones out there. As with, you can see, mom and dad picked a damn diaper. Something's wrong. That's that irritant. Okay? It's been a long since I've had a baby, so I don't brand names anymore. Like I can see one that's like starts with a P. Pampers. I mean, that's just too hard. Anyways. So that's an irritant that is located in that area. The next picture is an irritant in a big spot. So I won't even ask what she's been using because it's all over the place. Okay? We can have those on the hands. Again, on the dorsal aspect. So those are those irritant things. Something is pissing it off and you need to get rid of that. You need to go away from that. It's most likely or most commonly on our hands. Unless you're putting something somewhere else. Okay? Now when I talked about those eczema things, we talked about the nummular, right? And then I joked about the nickel, okay? Nickel is the most common cause of allergic contact dermatitis. But you've got other things, right? Number 2 is poison ivy. And then it can also be potential sensitizers. So you got topical irritants like dyes, soaps, chemicals, plants. Those are the other things out there. Morphological wise, so it's got erythematous, inflamed, swollen, vesicular, bullous, exudative with crusting, intense pruritus. So they've got that itchiness that is happening on it. It can occur anywhere where the contact is made. It's not on both sides, it's asymmetrical. So where is that contact happening that allergy is at that is causing this to happen? Well defined, sharply demarcated, right? So it's just like that coin, the nickel. This will show up lineal, so that's that ruse. So poison ivy, right? What happens? We have those bullae that happen where the poison ivy goes and touches of the skin. Shaped, it can be ring, a watch. It can be, if you're putting a nickel watch on, then you can have that happen and it looks like a watch. Again, allergic contact dermatitis is an allergic response. There it shows you some of the locations there. So we can see that happening where we're putting stuff some nickel stuff that is causing it to happen. So it talks about nickel, rubber, clothing, those things that are causing that allergic reaction. Okay? I talk about the patch testing. It literally looks like that. Has anyone ever had that? No? Okay. It is all over your back, and they put dots of all of those things, and then they'll see you back like a day after, take all that off, and see where it is red and what is causing that to happen. So that's how it looks. Management-wise, identification and avoidance of the allergen. So what is causing that to happen? So let's get this out. Potent topical, so mild to moderate, or oral steroid if it's severe. Okay, again, y'all know that all of the oral steroids, we use them, we always have to taper them off. So it's not going to be completely stopped. We're going to go a week of, 2 pills, the next week 1 pill, another week half a pill, back and forth. We also want to do some of those antihistamines or cool, wet compresses. Picture-wise, here's nickel allergy. So that is because something of that earring has nickel, something of that necklace has nickel. And what's number 2? Well, okay, good. That's a wonderful pen. Like, that looks like it's back in the 60s or something, because we don't even have an eraser like that anymore. Also on the belt, okay, so we can see that irritating that area. Number 2, poison ivy. So you have those things there. It's more linear, right? So it's where that leaf travels across. So it's going to happen at that same spot. Again, pretty sure it's not his underwear, but something of a belt, yada yada. Yeah, some of these pictures are old as heck. All right. Those are the 2 of the contact dermatitis. So irritant, because there's something that's pissing it off, or allergic, something is you don't like. Your skin doesn't like it. Any questions? All right, so